Good morning, everyone. For our case explainer on rounds today, I've got a really fascinating one for us. We are going to unravel the clinical mystery of a 68-year-old patient who literally became terrified of lunch. As I walk you through her presentation, we'll see exactly how a classic triad of symptoms can easily hide behind completely normal preliminary workups if we aren't looking at the right physiologic phase. This is a story of intestinal angina, the deliberate fear of eating, and exactly why 2 out of 3 major splanchnic vessels have to go down before a patient ever feels a thing.
So, here is our roadmap for the presentation. We'll start with her admission presentation, take a deep dive into the pathophysiology, walk through our assessment and plan, and then wrap up with the disposition and some high-yield teaching pearls.
All right, let's jump right into Act 1, the admission presentation. We're admitting a 68-year-old woman, and she has a classic vascular path profile. She's lost a whopping 30 pounds over the last 6 months. But her story is incredibly specific. She's intentionally skipping meals because roughly 15 to 30 minutes after eating, she gets this predictable, dull, cramping periumbilical pain. It lasts an hour or two, gets way worse with large or fatty meals, and it's somewhat better if she strictly eats small amounts. Because of this, she's developed severe Sitophobia, meaning she is terrified to eat, not because she doesn't have an appetite, but because the pain is just perfectly reproducible. She has no hematochezia, no melena, no vomiting. Now, her history? It's a massive red flag. 50 pack years of smoking, coronary artery disease with 2 prior stents, peripheral artery disease with claudication, hypertension, and hyperlipidemia. She's currently on aspirin and a high-intensity statin. On exam, she looks cachectic, she has temporal wasting, but here's the kicker. Her abdomen is remarkably quiet. It's soft, non-distended, no guarding, no rebound, maybe just some mild periumbilical tenderness at most. She does have an epigastric bruit, but we know that's present in some, absent in many, and honestly never diagnostic. Her distal pulses are diminished, and she has femoral bruits.
Now, looking at her prior outpatient workup, there's a glaring gap. She recently had an endoscopy, a mesenteric duplex ultrasound, a routine abdominal CT, and a colonoscopy. Every single one of them was completely normal. So we really have to ask, why did standard structural exams completely miss the true culprit here? Anticipating your questions on this, Dr. Smith, why didn't her soft abdomen rule out ischemia? Well, because this is entirely a supply and demand mismatch right at the mucosal level. It's not a transmural infarction that would give us peritoneal signs like guarding or rebound. Second, why did the first CT miss it? Simply put, a routine CT without arterial-phase timing is just going to completely miss those osteal stenosis. And finally, why isn't this weight loss just from malabsorption? Because her resting blood flow is actually adequate enough to keep the bowel alive and absorbing between meals. That 30-pound drop, it's 100% voluntary caloric restriction because eating simply hurts too much.
Okay, to solve this diagnostic mystery, let's move to Act 2, the pathophysiology deep dive.
To really understand this, we need to look at how brilliantly redundant the gut's blood supply actually is. The celiac, the superior mesenteric, and the inferior mesenteric arteries are all hardwired together through an amazing collateral network. The celiac supplies the foregut. The superior mesenteric, or SMA, supplies the midgut, which is obviously a huge territory. And the inferior mesenteric, or IMA, takes care of the hindgut. But they don't operate in isolation. The celiac and SMA are bridged by the pancreaticoduodenal arcades. The SMA and IMA are linked up by the marginal artery of Drummond and the arc of Riolan. And then the IMA connects down to the internal iliac system via the pelvic escape route, which is the superior to middle and inferior rectal arteries.
And because those collaterals are so incredibly robust, a patient usually needs a slow, progressive stenosis in at least 2 out of those 3 vessels before they even show a single symptom. If just one vessel goes down, it's almost always completely silent because the collateral network fully steps up to bat. Mesenteric atherosclerosis is slow, and it happens overwhelmingly right at the vessel origins directly off the aorta, which gives those collaterals plenty of time to grow and enlarge. That magic threshold, 2 out of 3 vessels compromised, is exactly why this disease presents so late in its clinical course.
If we want a perfect mental model for this, just look at how chronic mesenteric ischemia mirrors stable cardiac angina. It's a fixed supply problem, only the stress test trigger here isn't going for a jog, it's eating a meal. When food hits the gut, digestion kicks in and metabolic demand skyrockets. Normally, splanchnic blood flow should double within 20 to 30 minutes of eating. But with our patient's fixed atherosclerotic narrowings, that maximum flow is severely capped. The supply absolutely cannot meet the new postprandial demand. The result is anaerobic metabolism in the bowel wall, causing that awful, visceral, poorly localized cramping pain. Just like the heart, it's a fixed stenosis causing pain on demand, which is only relieved by resting the organ, meaning fasting.
And this creates a really devastating behavioral loop. Step 1. Eating causes pain. Step 2. The patient develops intense sitophobia, a deliberate fear of food. Step 3. Profound 20 to 40 pound weight loss. This specific cycle is how we separate this from its mimics. When an elderly patient comes in with abdominal pain and severe weight loss, our minds usually jump to ruling out malignancy first, right? Pancreatic, gastric, or colon cancer. We also think about luminal issues like peptic ulcer disease or gastroparesis, and we might even consider median arcuate ligament syndrome, or MALS. But MALS is an external compression by the diaphragm, typically seen in young, thin women in their 20s to 40s who don't have atherosclerotic risk factors. Our patient is the polar opposite. She's an older vasculopathy, whose weight loss is the direct consequence of that brutal sitophobia cycle.
Now here is something we absolutely must remember on the wards. If that pain stops being predictable and suddenly becomes constant, the plaque has likely thrombosed. We've just gone from a chronic clinic problem to an acute vascular emergency measured in hours. That is the ultimate red flag. If a patient with known intestinal angina gets constant pain that is sudden, severe, and wildly out of proportion to a benign abdominal exam, their flow has dropped below baseline resting requirements. The bowel isn't just ischemic during meals anymore, it is actively infarcting, and that means acute mesenteric ischemia requiring emergent CTA and an immediate surgical consult.
All right, that brings us to Act 3, Assessment and Plan.
We know basic lab work won't make this diagnosis. A normal lactate doesn't mean a thing here because the bowel isn't infarcting between meals. We're only going to see the nutritional fallout like low albumin and micronutrient deficiencies, so our imaging has to be very deliberate. The reason those previous normal CT scans completely missed this is that they lacked arterial-phase timing. That timing is the absolute requirement for spotting those osteal blockages. Sure, a mesenteric duplex ultrasound is a decent non-invasive screen to check for elevated peak systolic velocities, but it's superoperator and body habitus dependent. Computed tomography angiography, CTA, with arterial-phase timing is our real workhorse. We ordered this CTA for our patient and boom, it showed exactly what we suspected. High-grade osteal calcified plaque in both the celiac and superior mesenteric arteries, along with massively enlarged collateral arcades trying their best to bridge the gap.
So, how do we fix the plumbing? We have to honestly weigh the trade-offs. Surgical revascularization, like a bypass graft or an endarterectomy, gives us better long-term patency, but it comes with a much higher perioperative morbidity. That route is generally favored for younger, fitter patients. On the flip side, endovascular angioplasty and stenting offers percutaneous entry, lower upfront risk, and a shorter hospital stay. But you do accept a higher restenosis rate that might require repeat interventions. Given our patient's profound deconditioning, sarcopenia, and that massive 30-pound weight loss, open surgery is just way too risky right now. After consulting with vascular surgery, we opted for angioplasty and stenting of her SMA.
But remember, the stent doesn't cure her underlying systemic disease or the malnutrition. Her medical therapy continues regardless. We need to optimize our nutrition, sometimes even using total parenteral nutrition beforehand if things are severe. And when she starts feeding again, we have to watch her phosphate, potassium, and magnesium like a hawk, because refeeding syndrome is a very real hazard after months of strict restriction. Plus, this is a systemic atherosclerotic disease, right? Smoking cessation is literally the single highest yield intervention we can offer her. She's also going to need a high-intensity statin, dual antiplatelet therapy for the stent per vascular protocols, and incredibly tight blood pressure control.
Finally, let's wrap up with Act 4, Disposition and Teaching Pearls.
Post-stenting, the trajectory for these patients is just incredibly rewarding. By day 1, our patient was already eating full meals completely pain-free. Before disposition, we enrolled her in a comprehensive smoking cessation program. And over the next 1 to 3 months, we expect steady, progressive weight regain. We'll obviously keep an eye on her with surveillance imaging for any signs of in-stet restenosis, and our nutritional recovery will definitely take months, not days. But our sitophobia, it's cured.
If we take away anything from this case explainer today, let it be the classic triad: predictable postprandial pain, fear of food, and significant weight loss in a patient with a history of vascular disease. That is chronic mesenteric ischemia until proven otherwise. We really can't brush off deliberate food avoidance in these patients as anorexia or depression, and we definitely shouldn't stop digging just because the initial cancer screen is negative. If they have coronary disease, peripheral artery disease, and a heavy smoking history, their mesenteric vessels are just the next domino to fall.
Also, a huge teaching pearl here. A soft, non-tender abdomen and a totally normal endoscopy absolutely do not exclude this diagnosis. This is a vascular supply issue, so the abdominal exam is often going to be remarkably soft and benign, totally belying how serious the patient's story is. A normal endoscopy only looks at the superficial mucosa of the foregut. It doesn't stress test the flow to that massive midgut territory. Relying on an absent abdominal bruit to rule this out is a major pitfall. We simply have to listen to the story the patient is telling us about the predictability of their pain.
So, the final provocative question for all of us is this: will we remember to verify arterial-phase timing the next time we see a negative abdominal CT in a patient who is literally afraid to eat? The right imaging protocol makes the diagnosis, the wrong one hides it. By understanding the anatomy, that two-vessel collateral threshold, and the postprandial demand mismatch, we can save these patients from progressive starvation and stop a catastrophic acute thrombosis before it happens. Thanks for letting me present this case on Rounds today.